Yeah, good evening, everyone. Uh, Thanks, Dr. Tarun, for nice words. Before I begin my presentation, I have a few confessions to make. Uh, First is that I'm a clinical endocrinologist, so this is what my presentation will look like. It will be more about clinics rather than talking about all the hormones. So I try to incorporate all the major hormones, but because of the time limitations, I'm not going into the very finer details of the subject. Secondly, I was passed on an information. So this is a secret that information that was passed on to me by Dr. Hari and Dr. Saptrishi, that these webinars are slightly different than what we routinely see. Here, the questions will be passed on to the chairpersons rather than to me. So, chairpersons, I am sharing this information with you. You are the one who are going to give the answers to all the questions. So, with with this information, in next 30 or minutes or so, we'll be talking about the physiology of lipid metabolism. We'll be talking about exogenous pathway, the endogenous pathway, and the HDL metabolism, and we'll be talking about the effect of hormones on lipid metabolism. Predominantly, we'll be talking about thyroid, cortisol, prolactin, and sex steroids. Insulin and glucagon, I'll be talking in very short 2 or 3 slides because I believe it is completely a separate topic and requires a separate seminar if we want to discuss the effect of insulin on lipid metabolism. So, if we talk about lipid metabolism, we now understand that fields of endocrinology and metabolism is now rapidly expanding, especially in this post-COVID world when we know that COVID is going to affect the metabolism and it is going to affect our body's metabolism in such a way that various hormones are going to change, and the number of patients with diabetes with dyslipidemia are going to increase. So there is a complex interplay of endocrine hormones and the lipid physiology. There is multiple effects how a particular hormone affects not only the lipid metabolism, but increase or reduction of one hormone also leads to changes in another hormone. For example, hyperprolactinemia is associated with low estrogen levels. Acromegaly is associated with insulin resistance. So there is a complex interplay of hormones that leads to changes in lipid metabolism or energy metabolism of the body. And based on the newer information that we are gaining through understanding of these hormones, newer therapeutic approaches are now developed to control dyslipidemia. Like there were few of the questions that were asked by Dr. Premvada in her presentation, the newer techniques that we are now using for controlling the dyslipidemia. But the challenge is, how can we incorporate this knowledge into clinical practice? Because as clinicians, like Dr. Hari was saying, that this topic used to be more of an exam topic rather than a clinical topic. We used to study during our exams the effects of hormones on lipids, but actually the use in practice is not to that extent. So one of the challenge is how we can actually incorporate this knowledge into a clinical practice, and how we can make this knowledge more relevant in our day-to-day clinical practice, so that we are able to improve our patients' routine clinical care. So talking about dyslipidemia, uh, dyslipidemia is common. If we look into the data, it is attributed to over 4 million deaths per annum. And this was 2002 report. Now, if we look into the recent reports, probably the number of deaths will be way more. And if we look into the prevalence of hypercholesterolemia, as per the WHO MONICA project, around 53% of men and around 40% of women had dyslipidemia of some sort. If we look into the Indian study, the ICMR India study, it showed that there was dyslipidemia to the tune of around 70%. One component, low HDL, was seen in around 70% of the patients with diabetes, high triglyceride in around 30%, and high LDL in around 12%, thus increasing the risk of CV burden in this population. Another study from India, the Fit Heart study, which was done over 20 states, showed the prevalence of hypertriglyceridemia to be around 43%. So this is a major problem, and very large chunk of our patients do come with this problem in our routine OPD, and we see a lot of problems in the lipid profile of our patients. If we understand the pathophysiology of dyslipidemia, it can be genetic, but predominantly what we see is secondary causes, whether it is obesity, whether it is diabetes, PCOS, thyroid dysfunction, and the less common causes like hypogonadism, hyperprolactinemia, Cushing's, which are more commonly seen in endocrine OPDs, the growth hormone deficiency, acromegaly. So these are all the conditions that are associated with increased CV risk, mortality, and morbidity. And various studies have shown that the most common cause of death in many of these conditions is CV death. So again, dyslipidemia is the root cause of CV mortality, and when we understand that these hormones do play a role in the pathogenesis of dyslipidemia in these patients. So one of the studies which looked into referred patients showed that 1/3 of the patients with dyslipidemia had secondary conditions contributing to lipid abnormalities. So now we understand that both endocrine system and energy metabolism are very closely interlinked. If there are any changes in the endocrine system, whether it is a growth hormone deficiency, or it is hypercholesterolemia, or hyperinsulinemia, or insulin deficiency, everything is closely interlinked with energy metabolism. So is energy metabolism linked with endocrine system. So there is a bidirectional relationship between endocrine physiology and metabolism. So if we look into the prevalence of dyslipidemia and endocrine disorders, both have genetic and environmental factors which contribute to the development of these disorders. And it is important to understand the various physiological links that exist between the hormones and energy metabolism. And this is what we are going to talk in next few minutes. So to understand this relationship, this was a very interesting term coined by Dr. Kalra and Dr. Gaganpriya, where they called it lipocrinology. They use this term because they highlighted the importance of endocrinology, that is hormonology, with lipidology, and they combined this term because both of these things are so intimately linked to each other that they cannot be separated from each other. So lipocrinology by definition is the study of interrelationship between lipid metabolism and endocrine function in health and disease. So if we talk about physiology of lipid metabolism, this is a very brief overview of physiology. If we look into the lipoprotein structure, lipoprotein in its core contains triglyceride or cholesterol ester. The outer boundary consists of hydrophobic cholesterol esters, and there are phospholipids and apolipoproteins, which not only governs their function, but also are important inducers of various other enzymes. The four major lipoprotein classes are high density, low density, very low density, and chylomicrons. The major difference is between the density of these lipid particles, and the difference is because of the presence of cholesterol, esterol, or triglyceride in this. More amount of triglyceride, lesser dense is the molecule. For example, chylomicrons have the least density as compared to HDL, which have a very high cholesterol ester compounds in them. The various apolipoproteins, like apolipoprotein A1 is the major apolipoprotein of high HDL. LDL, the B100 molecule is the major apolipoprotein, and other B and other C apolipoproteins are present in VLDL and chylomicrons. So talking about the exogenous pathway of lipid metabolism, once we eat food, whatever we eat food through the gut, all the fat is then all the glycerol and triglyceride from the fat are esterified and assembled into a molecule called as chylomicrons. So these chylomicrons have a large amount of triglycerides, and once these enter into the circulation, they are acted upon by lipoprotein lipase. So lipoprotein, with the help of this lipoprotein lipase, fatty acids are taken from chylomicron by the tissues which use these triglyceride and fatty acids for their metabolism. And what is left is a chylomicron remnant. So these chylomicron remnants are again acted upon by lipoprotein lipase, and then they develop intermediate density lipoproteins, which are then converted into either LDL or taken by the liver itself. So that I'll be showing you in next few slides in the endogenous pathway. So this is what the exogenous pathway is. Exogenous pathway means whatever we are eating, this is how it reaches to different tissue and the liver. So the endogenous pathway begins with the synthesis of nascent VLDL particles from the liver. These nascent VLDL particles contain ApoB100. Cholesterol esters and various other lipoproteins are then incorporated into these nascent VLDL through the HDL molecule. So there are various enzymes through which HDL molecule passes on cholesterol esters to these nascent VLDL molecules, and this leads to formation of mature VLDL molecules. So again, the lipoprotein lipase acts on these mature VLDL molecules, and then the tissues take away phospholipids, fatty acids, and what remains is a VLDL remnant. Now, this VLDL remnant is acted upon by hepatic lipase, and these are either taken up by the liver, or this leads to formation of LDL particles, which has ApoB100 acids, major lipoprotein. So to understand this completely, this is what happens in the small intestine. Whenever we take dietary lipids, chylomicrons are formed. So these chylomicrons are taken up into the circulation, and these are acted upon by lipoprotein lipase. And these free fatty acids which are released are taken up by muscles or adipose tissue for their metabolism. What remains is a chylomicron remnant, and these chylomicron remnants are taken up by the liver through LDL receptors. If we look into the endogenous pathway, it is the liver that synthesizes the nascent VLDL, and it is the HDL particles which gives these nascent VLDLs more fatty acids and more triglycerides, and these forms the mature VLDL molecule. Now again, lipoprotein lipase acts, and what remains is the intermediate density lipoprotein. This intermediate density lipoprotein is acted upon by the hepatic lipase. Either they are taken up by the liver directly, or this leads to the formation of LDL particles, which are again taken up by the liver. So this is what the exogenous and endogenous pathways look like. There is another pathway, the reverse cholesterol transport pathway, that is also known as the HDL metabolism pathway. We know that each and every cell and each and every tissue in the body forms cholesterol, and this pathway helps in bringing back these cholesterol back to the liver for metabolism. So in the extrahepatic tissues, the cholesterol is transferred to the nascent HDL pathway, nascent HDL molecule, with the help of this enzyme, which is also known as ABCA1. These nascent HDL particles are able to acquire more cholesterol esters from various other sources through the enzyme that is known as LCAT, or the cholesterol acyl transferase enzyme. This mature LDL molecule is acted upon by the CETP enzyme. So this enzyme, what this enzyme does is, there is a bidirectional transport of either cholesterol or triglyceride from various other molecules like VLDL or LDL. So once these mature HDL molecules, which have very low levels of triglyceride, acquire more triglyceride, then they become HDL type 2 particles, and these HDL type 2 or type 3 particles are then acted upon by hepatic lipase, and the free fatty acids is then utilized by the liver for formation of cholesterol or for formation of bile. Again, these mature HDL particles can be directly taken up by liver by the help of this molecule, which is also known as SRB1. So HDL pathway is the pathway from which the extra hepatic tissue that forms cholesterol is transported back to liver for synthesis of bile or for synthesis of cholesterol. So this is what HDL does in the body. So this was the basic about lipid metabolism. If you are still finding it difficult to understand all of this, probably in the next few slides, I'll be talking more about clinical lipidology. And if you are able to just grasp that, probably that will also help you in managing your patients more easily. So like I told you, I'll be talking very less about insulin and various other, because I believe it's a very large topic. Insulin increases the clearance of triglyceride-rich chylomicrons from the circulation, this through the stimulation of lipoprotein lipase. So I showed you in my initial presentation that the chylomicron molecules that comes through the diet are acted upon by lipoprotein lipase, and these fatty acids are then utilized either by the fat or by muscles. But we have to understand that insulin activates the adipose tissue lipoprotein lipase more, but inhibits the same in skeletal muscle, so that more amount of these fatty acids are absorbed in the adipose tissue. It also leads to re-esterification of free fatty acids into triglyceride within fat cells, so that these fatty acids are not used for energy metabolism, and these fatty acids are stored in the fat cells itself. So this is what we see during severe insulin deficiency in decay, that there is reduction in insulin levels and there is breaking of these fatty acids in the fat cells, and the ketone bodies that are produced are then used as an energy source. Insulin also inhibits lipolysis of stored triglyceride by inhibiting hormone sensitive lipase. So hormone sensitive lipase is present in each and every tissue, and the main action of hormone sensitive lipase is to hydrolyze these triglyceride for energy. So if we look into the action of insulin and like glucagon, insulin inhibits hormone sensitive lipase, glucagon stimulates hormone sensitive lipase. So this is what happens if you see in this beautiful picture. Insulin, as we all know, has a positive effect on the GLUT4 transmembrane protein, and this leads to increased flux of glucose into the intracellular pathway. Once the glucose level increases beyond a certain limit, this free glucose is then used to form triacylglycerol. This triacylglycerol is then at the time of requirement is acted upon by hormone sensitive lipase, which leads to formation of glycerol or free fatty acids, which are used as an energy source. Like I told you, insulin also act upon lipoprotein lipase, especially at the level of adipose tissue, so that more amount of the dietary triacylglycerol are fluxed into the adipose tissue for storage. So this is where glucagon acts. Glucagon has a positive effect on hormone sensitive lipase. Insulin has a negative effect on hormone sensitive lipase. So this is what I will limit my discussion on insulin and glucagon, because I believe it requires a quite large amount of time to just discuss these two molecules. So now talking about thyroid and lipids, the association between thyroid diseases and serum cholesterol was studied way back in 1930s. As early as 1951, SCO reported that there is an increased fat accumulation in the tissues of hypothyroid mouse models. If we look into the prevalence of hypothyroidism in patients who have hyperlipidemia, for example, we are just looking at patients with hyperlipidemia and we look into the prevalence of hypothyroidism in these patients, it is to the tune of 1.4 to 13%, thus suggesting that thyroid is integrally related with lipid metabolism. Lipid levels increases in a graded fashion as thyroid function declines. Patients with subclinical hypothyroidism will be having lesser changes in their lipid metabolism vis-a-vis patient who have overt hypothyroidism, who will be having a very large amount of changes in their lipid metabolism. So if we look into the pathways or how thyroid hormone regulates lipid metabolism, so it is a very complex pathway. Thyroid hormone has a direct stimulation of LDL receptor. So thyroid hormone act at the genomic level and they increase the expression of LDL receptor. This they do directly as well as through another co-stimulatory protein, that is SREB2, and this leads to increased expression of LDL receptor. They also have a negative association with PCSK9 levels, and if we remember that PCSK9 is a protein, once it increases, it reduces the LDL receptors. That is why we use PCSK9 inhibitors for treatment of dyslipidemia. So thyroid hormone has a negative effect on PCSK9 levels, and this also leads to increase in LDL receptors, which leads to increased hepatic clearance of LDL. Not only this, there is also an increase in bile synthesis and cholesterol excretion by their direct action on CYP7A1 protein. So if we look into the HDL metabolism, thyroid hormone also has a direct effect on the CETP gene, the LCAT gene, thus leading to increased transfer of cholesterol esters from HDL to VLDL, and thyroid hormone also acts directly on hepatic lipase, thus increasing the conversion of intermediate density lipoproteins to LDL, which are then taken up by the liver and thus leading to reduction in LDL levels. If we look into the effects of T3, T3 increases the bile acids flow. It leads to depletion of hepatic cholesterol. It leads to increase in synthesis of cholesterol, and there is increased cholesterol uptake from the circulation. And lack of T3, that is hypothyroidism, is associated with the reduction of this bile acid flow, depletion of hepatic cholesterol, increased intrahepatic cholesterol, and reduced cholesterol uptake from the circulation. So looking on the effect of thyroid disorders on lipids, if we look at the total cholesterol levels, like I told you, that there is a graded increase in the levels of dyslipidemia once the disease turns from subclinical state to overt state. The total cholesterol are normal or maybe slightly increased in subclinical hypothyroidism, but it is increased in overt hypothyroidism. There is no change in HDL level in either of the state, or there is slight increase in overt hypothyroidism. LDL, we know that it is increased, and I told you in detail why LDL increases in hypothyroidism. Triglycerides are normal. So this is an important clinical point over here. If in your OPD, you see a patient with hypothyroid who is having high triglyceride levels, I'll start thinking about diabetes more in this patient. And if rather than if my patient is just having a high LDL, if my patient is having high LDL, I will correlate it with overt hypothyroidism, but increased triglyceride in that patient along with increased LDL will force me to look into his blood glucose levels as well. So this is, I believe, is an important clinical point that we should remember. Other lipoproteins like lipoprotein A or apolipoprotein are not changed in subclinical hypothyroidism, but these are increased in overt hypothyroidism. All of these changes increase CV risk in patient with hypothyroidism, and that is why many of the newer guidelines are now saying that we should be more stringent, or we should be more aggressive in treating patients with subclinical hypothyroidism. And there was a recent publication which has suggested that probably 7 is the new 10. Why I am saying so is, it was earlier said that once your TSH level increases beyond 10, this is when your CV risk disease increases. But now we have a publication last year in JCM which showed that once your TSH increases beyond 7, and if it is persistently above 7 over 12 weeks or so, probably these are the patients who should be treated to reduce their CV risk. Further, there is also evidence to suggest that dyslipidemia improves once we add levothyroxine treatment. So coming to mechanisms, I already told that the number of hepatic LDL receptors are reduced in hypothyroidism, which leads to reduction in clearance of circulating LDL. Further, PCSK9 levels are increased in patients with hypothyroidism, which is associated with reduced clearance of LDL and increased formation of LDL particle. Further, there is a reduction in lipoprotein lipase activity, which could lead to reduced clearance of triglyceride-rich lipoprotein, accounting for a very small increase of plasma triglyceride levels in hypothyroidism. But if you are seeing very high triglyceride levels in your patients, probably you should think about diabetes in these patients. So we have talked about hypothyroidism. Coming to hyperthyroidism, the effects are totally opposite. The total cholesterol is reduced, LDL cholesterol is reduced, HDL cholesterol is reduced, the effect on triglycerides is again variable, and all of the apolipoproteins, whether it is lipoprotein A, apolipoprotein B, or apolipoprotein A1, all are reduced. The mechanisms are exactly opposite. There is a decrease in LDL cholesterol because there are increased hepatic LDL receptors. I showed you that the thyroid hormone directly acts at the genomic levels to increase the expression of LDL receptors. Further, there is evidence to suggest that there is reduction in PCSK9 levels. The effect on HDL metabolism is complex, and it has been shown that thyroid hormones increases CETP, hepatic lipase, and the SRB1 protein levels, which are associated with reduction in HDL levels by increasing HDL metabolism. Coming to our next hormone, the cortisol, the effects of glucocorticoids on lipid metabolism are again complex because cortisol increases whole body lipolysis. It has been shown that glucocorticoids induce hormone-sensitive lipase activity in adipose tissue and thus augmenting intra-adipocyte triglyceride hydrolysis. Further, hypercortisolemia also stimulates lipoprotein lipase activity, which is further potentiated by hyperinsulinemia, which is seen in patients with increased cortisol levels. This leads to intravascular lipolysis, which leads to increased uptake of non-esterified fatty acids and glycerol in adipose tissue. So coming to the effects associated with glucocorticoids, this is a very complex table. If we look into the effects of glucocorticoid, it increases lipogenesis. This is because of increased activity of lipoprotein lipase, increased activity of acetyl coenzyme A carboxylase, increased activity of fatty acid synthetase. It increases lipolysis also by increasing hormone-sensitive lipase, by increasing adipose triglyceride lipase, by increasing AMP kinase in visceral fat, and there is a permissive effect on lipolytic effect of beta-adrenergic compounds by acting on their receptors. Further, because of increased insulin resistance, there is increased gluconeogenesis and there is reduced insulin signaling. The changes associated with these biochemical derangements is that the patient develops a Cushingoid habitus, there is an increased total fat mass, there is increased visceral and hepatic fat, the upper body subcutaneous fat increases, and there is a reduction in peripheral subcutaneous fat mass. There is an increase in total and LDL cholesterol, there is increase in triglyceride levels, the changes in HDL cholesterol are uncertain, and we all know that these patients also develop diabetes because of increased insulin resistance. So coming to Cushing's syndrome, like I told you, the changes associated with cortisol metabolism leads to an increased central and upper body fat distribution. There is a significant insulin resistance. There is presence of dyslipidemia, and this dyslipidemia correlates with the severity of hypercortisolism. CV risk is increased. And if we look into the studies that have looked into the mortality associated with Cushing syndrome, the most important cause of mortality in these patients is CV risk mortality. Serum lipids improve with medical or surgical management of Cushing's, and once this patient has improved of their Cushing's, the residual CV risk still remains, and probably these patients require an appropriate hypolipidemic drug during their post-recovery period. So there is an increase in total cholesterol, LDL cholesterol, and triglyceride levels. This is what has been shown. So this was one of our publications when I was in All India Institute. So this was my thesis also, and we looked into the pattern of lipid abnormalities among patients with Cushing syndrome, and we also looked into the short-term impact of surgical correction of hypercortisolemia in these patients. We studied approximately 100 patients with Cushing's. Around 73 had Cushing's disease, and 12 of them had adrenal, 7 of them had ectopic, and in 8 of these patients, we were not able to find any reasons for their Cushing's. These were on follow-up. What we saw was around 65% of our patients with Cushing's had some sort of dyslipidemia. Hypertriglyceridemia was one of the most common abnormality. It was seen in around 48 to 75% of the patients, depending upon the etiology. High LDL was also very common in our patients. We also looked into the background history of diabetes in these patients. And we showed that patients who had a family history of diabetes had a more severe dyslipidemia than those who did not have a family history of diabetes, thus telling us that the background metabolic abnormalities are also important in determining the amount of dyslipidemia that will be seen in your patient. We looked into the short-term changes in these lipid levels after surgery. So the post-surgery period, after 12 weeks of surgery, we again looked into the level of dyslipidemia. And what we saw was dyslipidemia still persisted in these patients, but the level of the various constituents of dyslipidemia, like cholesterol levels or triglyceride levels, or the low HDL levels that were seen, have actually improved post-surgery. So once these patients are cured of their Cushing's, their cholesterol levels do improve. But there is a baseline risk that remains with these patients, and probably these patients should be treated for a longer time to prevent CV mortality and morbidity in these patients. Coming to the lesser known hormones, prolactin. So if we look into the prolactin actually reduces lipoprotein lipase activity in human adipose tissue, and elevated prolactin levels are associated with reduction in estrogen levels in women, a change that is known to be associated with LDL cholesterol and a reduction in HDL cholesterol levels. Again, LDL level proteins are in elevated prolactin levels are also associated with obesity. Many of our PCOS patients, when we get their routine profile done, we see that they not only have elevated insulin levels, but also some of these patients have elevated prolactin levels as well. So this again adversely affects plasma lipid levels. In very large prolactinomas, the secretion of growth hormone is also impaired, and I'll be showing you in next few slides how growth hormone deficiency also leads to dyslipidemia, and probably this is also one of the mechanisms with which hyperprolactinemia leads to dyslipidemia. So I hope we are not running short of time. So I'll just try to wrap it up.
We have another 10 minutes to go.
Yeah, sure. So if we look into the effect of the total cholesterol increases, the LDL cholesterol increases, but there is no appreciable change in HDL or triglyceride levels. Coming to growth hormone increases the expression of hepatic LDL receptors, and this is also seen at the genomic level, thus reducing LDL levels, which is seen in patients with acromegaly. Growth hormone also stimulates lipolysis in the adipose tissue, which provides fatty acids for the synthesis of triglycerides, and this is associated with enhanced VLDL production. Growth hormone administration, once we give growth hormone, it increases the mRNA levels of apolipoprotein A, and plasma levels of apolipoprotein also increases. So if we talk about growth hormone deficiency, the major thing that is seen is increase in triglyceride levels, and this is because of reduced clearance of VLDL because of effect on lipoprotein lipase, and there is also an increase in LDL cholesterol levels because growth hormone directly affects the LDL receptor protein. Acromegaly is associated with again increased triglyceride levels. So both deficiency and excess of growth hormone are associated with increased triglyceride levels. But here the reason is increased production of triglyceride levels as opposed to reduced catabolism of triglyceride in deficiency, growth hormone deficiency. Serum testosterone directly correlates with HDL cholesterol and apolipoprotein. Low testosterone levels are inversely correlated with total cholesterol, LDL cholesterol, and apolipoprotein levels. If we look into the correlation of testosterone, HDL has a positive correlation. That means higher the testosterone, higher HDL, lower testosterone, lower HDL cholesterol. All other components of lipid profile that we see, whether it is LDL, triglyceride, or lipoprotein, have lipoprotein A have a negative correlation with serum testosterone levels. Once we start testosterone therapy, the HDL cholesterol actually reduces, and this is the most consistent effect that is seen with the testosterone therapy. This is because of increased expression of SRB1 levels in the liver, which leads to increased metabolism of HDL cholesterol, and this leads to reduction in HDL cholesterol levels. Very commonly, we are using androgen deprivation therapy, especially in patients with prostate cancer. We either do an orchectomy or we use GnRH receptor agonist, and these are associated with an increase in HDL. But overall, the picture remains atherogenic in these patients because of increase in triglyceride, increase in LDL cholesterol, and this increased triglyceride, when they are present together with increased LDL, they lead to formation of small dense LDL particles, which are associated with higher CV risk mortality and morbidity. Coming to estrogen, we know that premenopausal women have lesser pro-atherogenic lipid profile as compared to men. Prior to puberty, the lipid profile of girls and boys are very similar, but once they hit puberty, the HDL cholesterol start to dip in boys, and the difference reaches to around 10 milligram per deciliter. During puberty, triglyceride levels in boys increases with no changes occurring in girls. Comparing premenopausal women to men, like I told you, premenopausal women have a lower LDL, they have a higher HDL and a lower triglyceride level as compared to men. Once these women transit to postmenopausal state, there is an increase in LDL cholesterol. There is either no change or very small reduction in HDL cholesterol, and there is no change in lipoprotein A levels. So probably it is the LDL cholesterol increase that is associated with increased CV risk that is seen in women after menopause. But we have to understand that these changes become more robust if a particular woman have achieved a surgical menopause. That means they have undergone an orchectomy. These women have a higher risk of developing CV disease because of more severe dyslipidemia that is seen in these patients. Now we look into the effect of oral estrogen, because many of our patients are on oral estrogen. Once these patients are started on oral estrogen, there is a reduction in LDL cholesterol, there is an increase in HDL cholesterol, and increase in triglyceride level. Estrogen administration increases HDL cholesterol levels by 5 to 15% and reduces LDL cholesterol levels by around 20%. Approximately around 10 to 15 milligram per deciliter increase is seen in triglyceride levels with estrogen therapy. One of the most commonly discussed, I believe, topic is the effect of postmenopausal hormone therapy. After, I believe, once WHO trial was published, all of us became a bit skeptical to use because of the increased CV risk associated. But we have to understand that the CV risk is different with different molecules, and this is what I believe. There was a question on this in Dr. Premva's quiz also. You see that once your patient is using only estrogen, there is around 1.2% reduction in HDL cholesterol, 4% reduction in LDL cholesterol, and 3% reduction in triglyceride level. But once we add a progesterone like medroxyprogesterone acetate, there is a significant increase in there is a significant change in cholesterol levels in these patients. But these changes are not significant once these patients are given a more natural form of progesterone like micronized progesterone. Coming to polycystic ovary syndrome, one of the syndromes that has been recently been shown to have an increased CV risk and increased metabolic chances of developing metabolic syndrome. The dyslipidemia is, again, it shows high LDL levels, reduced HDL levels, and increase in triglyceride levels. So this was another publication that we did during my stay at AIIMS, and we tried to look into the phenotypic differences in the patients from Srinagar and from Delhi, and we saw that patients from Delhi had higher dyslipidemia as compared to those from Srinagar. They had higher total cholesterol levels because of higher presence of diabetes in the background in patients from Delhi. So we concluded that in Delhi, we have more of a metabolic phenotype of problems with PCOS, whereas in Srinagar, we had more of androgen type of cases from Srinagar. So coming to the mechanisms, estrogen stimulates the expression of apolipoprotein A. This leads to increased formation of HDL. It also decreases hepatic lipase activity, thus reducing the hydrolysis of triglyceride and hydrolysis of HDL particles. It suppresses the expression of SRB1, thus increasing the HDL levels in the blood. Estrogen further increases the expression of hepatic LDL receptors and reduces PCSK9 levels, leading to reduction in LDL levels. And the increase in plasma triglyceride levels that is seen with estrogen treatment is because of increased production and secretion of VLDL particles. The adverse effects associated with progestins on lipids and lipoproteins are mainly because of androgenic property of these progestins, and it is through the activation of androgen receptors. And the variation that is seen with medroxyprogesterone acetate versus micronized progesterone is because of the different androgenic potency of these molecules. So I think one of my slides I missed. So to summarize, I believe both endocrinology and lipidology are intricately linked to each other, and the knowledge of one definitely helps in improving the outcomes related to other field. I'd like to acknowledge here Dr. Sanjay Kalra, because many of the slides here have been taken from him, and he has been one of the helping hands in preparing this whole presentation. Like Dr. Sandeep was saying, that we are living in tough times, but always remember that these tough times are not going to last. But if you are tough from inside, you will last. Thank you.